Now we're going into therapies. Therapies is going to be short and sweet and to the point, mainly because we have already gone through all the different theories that there are and the therapies that are truly associated with them. So, what are the main reasons that people seek help? Actually, it's not for disorders at all. What we find is that people come most often for personal fulfillment and coping with everyday challenges. And we have way more of them than we do with people that have psychological disorders. And then we have those that come in that are just looking for greater self knowledge. Now, why is that? It actually has to do with insurance and your capabilities of paying for it or not. Those with psychological disorders tend to have an issue where they lose income because of the psychological disorder, and therefore they don't have the insurance to cover going to see a therapist to get it fixed. Middle income to higher end income people have the insurance to be able to see a therapist, and so what they tend to come in for are the top two things. Again, the history of mental health and where it came from. Remember, you were evil. You were possessed by demons. We do trephining. We do lobotomies. We do whippings and beatings, caging you and spinning you, all sorts of things to try and get that evil spirit out of you. So that's where the history of it came. So many people will look at psychology and go, oh, it's not a true science. And the main reason they believe that is because of its history instead of what we do now. Now we do that medical model, and the medical model actually is what makes it a science. It's all based off of research now. It's all based off of facts and data now, just the way the medical professions are. So some of our treatments that we had, one of the ones that was done during the moral treatment was the tranquilizing chair. And what happened was they could see that horses, if you blinded horses, horses would calm down. And so they thought, oh, hey, this could work with humans as well. So as you could see in the chair there's a place for them to defecate and urinate. This isn't a couple hour thing. This can be a couple day, couple week, couple month thing. And then they tie them down so they were unable to move, and then they blind them. So the problem with it is people have an innate fear of the dark, no matter what. That's why you pull your arm in, when it's hanging over the bed or whatever. You have an innate fear of the dark, innate fear of the unknown. So if they weren't insane, as they called it back then, prior to going in the tranquilizing chair, many of them became insane afterwards. Now, mind you, you could go in for a mental disorder at the time for not being able to pay your rent, for not being able to pay a bill, for a man didn't want his woman anymore. She got too old, wanted a new one. He'd say that she was mentally unstable and she was put away. It was really that easy. So there weren't any rules as to how this could happen. It can be just that people said you were and therefore you were. Okay. Here's an example of that trephining. You can see the hole in the side of their head. This person died after the first trephining. Many can, withstand, and we have gotten up to 15 holes in a skull. Here's an example of spinning. So they'd spin these people around and round, and not only until they vomited and defecated fully, but until blood was emitting from them. Now, what I really want you to see is what's in the background, and you could see people watching this. It was like, the gladiator deals. It was where people would come in and believe that these religious entities were fixing these people. They were helping. They'd bring their kids with them to watch the horrors of what would actually happen to these people. And the whole time firmly believing that they were doing the moral and ethical thing to try and help these individuals. Now, when we look at therapy, we do it, of course, medically, and we have psychotherapy and we have biomedical therapies. Now, psychotherapy is any kind of thing where you're doing, looking at their behaviors, their thinking, relationships, and emotions, and trying to correct those, where biomedical therapy is using medications or some kind of medical procedure to try and correct those symptoms. A lot of times what we use is what we call an eclectic approach, where we use a combination of both of those things. So when we go into the psychological aspect of it, or the psychotherapy, these are the main four that continue to be used: psychoanalysis, humanistic behavior, and cognitive therapies. So we have the first one under the psychodynamic or psychoanalytic. Of course, that was Freud that came up with psychoanalysis. Then we have humanistic, which was all about Carl Rogers and Maslow. And that's being the best that you can be. Client-centered therapy is what Rogers came up with. Behavioral therapy came up with Pavlov, Skinner, and all about conditioning people and reconditioning people. And then we have cognitive therapy, which is all about Beck and Ellis and their thinking and thought processes, and to trying to change those thinking and thought processes. So the first one we have is psychoanalysis, and we have the actual chair and the actual couch that Freud used. He believed he should be behind you so that you could think freely without him being an interference. He was all about the id, the ego, and the superego that we've already gone over. He was mainly into free association, making you speak freely about your memories, your dreams, and your feelings, and then interpreting those speaking freely sessions. And if you made any ums, ahs, that kind of stuff, what was there as far as Freudian slips, meaning your underlying thinking processes compared to what you actually said. Of course, mainly he thought that you come through life having been screwed up by your parents, and that they always weigh on you throughout your life. So, yep, here we go. Now, he also looked at resistance. That's when you have a block and you won't talk about it or can't talk about it. Many people will say, well, I don't want to talk about that, but yet they will talk about it. This is when we actually work with people that don't want to talk about it and really don't. So if they're trained well, they'll be able to go around it and say, fine, we won't talk about that, and go around it because they've got enough information elsewhere that they can sort of pick at it continuously until there's a point where the person will say, you know, actually, I've already talked about it and I've already brought it through. Then we have dreams. Of course, he was really big into dreams and what the plot of that dream was, not whether there was a tree there or not, but what was the whole theme of that dream. And then he really found that there was issues with transference. He found that whatever issues they have throughout their life, they transfer those issues onto their relationships in the future. He also found that there was problems with transference right in the psychotherapy sessions, meaning that there was a transference, because this is the best relationship you're going to have with a person. They're going to listen intently. It's all about you. There's a transference of feelings onto your therapist, whether it's of the opposing sex or the same sex or anything. There becomes relationship feelings, and he also dealt with that through transference. Now, when we look at psychodynamic therapy now compared to the way it used to be, there's fewer sessions. Freud felt that once you got in therapy, it was a lifelong thing. You never ended. Now, if you come in and say, all right, I got a phobia, we could say, all right, we got that done. We could get that done in 3 sessions if you do what we want, or we can get that done in 7 sessions. Whatever the issue is, you can come in, and they could tell you approximately how long it's going to take as long as you follow the directions. It's not as much about the id, the ego, and the superego. You face the therapist instead of behind the therapist, more taking in that humanism of Carl Rogers. And the focus is now on present day, not about your past. So your parents screwed you up. Freud always delved into that and stuck with it. The way psychodynamic therapy works now is, all right, we figure out what your past is. Now it's your past. Deal with it and move on. You cannot treat others poorly because of your past. So we've got to correct the way you focus on it and the way you deal with it. It can be an understanding of that past and why they behaved the way they did. But now you have to understand you and why you're behaving the way you are and alter that to meet the needs. It's more on self-awareness and understanding and insight into your unconscious and relationships. Now we're looking at how you relate to others and how to correct that. The humanistic theory is Rogers and Maslow, and of course it's all about self-acceptance, being the best that you can be, doing client-centered therapy where it's all about you, reaching your full potential. Personal fulfillment is a big one in this. Now, if we wanted to evaluate psychoanalytic theory compared to humanistic theory, the goals are different, the ways to improve, the content is different, how long it takes is different. So know that a lot of that psychoanalytic, they're looking at the past way of doing it, not the current way, because it's not about the past, it's about the present now. But a lot of the rest of it is the same. So when we talk to people that go to therapy, they'll say, oh yeah, they were really nice, but it didn't work for me. A lot of times it's because you're looking for a different type of therapist. Try somebody different. See what it is that they've been trained in. What was their first training in, because that's their fallback training. And make sure that you're looking for a therapist that is doing it the way you want it to be done. Then we have behavioral therapy. Behavioral therapy is all about Skinner and Pavlov. Watson's in there as well. And what we want to do is change your behavior. That's the whole point, change your behavior. So how do we change those behaviors? Behavioral therapy works a lot with addictions and panic attacks, by the way. So one of the ways that we could change your behavior is called counter conditioning. And counter conditioning is you have a learned fear response. You have a learned reaction. You have a learned way of doing things. And now we're going to unlearn that. We're going to relearn that. A lot of relaxation, meditation, learning how to relax certain muscles comes into play. Learning how to counteract fears comes into play. And you can actually go the opposite direction of the way you've learned to do things over time. And it doesn't take that long to get it done either. Another portion of counter conditioning can be aversive conditioning. So when we look at some of our therapies that are out there that work are exposure therapy. So this works with phobias a lot, where you tend to avoid the things you don't like. Now you're going to have exposure to it, whether it's at the beginning levels of just talking about it, then looking at a picture of it, then having it have a picture of it clear across the room, then close to you while you're holding it, then the real item being way across the room, and then closely moving it further and further close to you till it's on you and you're making friends with it. That's exposure until each level of anxiety goes down. Oh, the term most often used with it is habituate it, which means get used to it. Now, one of the exposure therapies that we can use, it's called systematic desensitization. Sometimes, like planes, people can't get on planes, so we can't just practice getting on and off a plane. They just don't allow that to happen. So what we'll use instead will be virtual reality, which tends to work very well. One of the big ones that we see quite often for a phobia will actually be the dentist. And so we use a systematic desensitization for that. And here's an example of systematic desensitization. You would rate all the things on this list from how much anxiety or fear you have for it. So down at the bottom is just driving past the dentist's office on a Sunday afternoon. That still gives that person a level 10 of anxiety. So what you're going to have to do is habituate to it, which means you drive past the dentist's office on a Sunday afternoon so often that there's no anxiety. That 10 goes down to a 0. Then we go up to the next one. We do the 15 until it goes down to a 0. Then you go up to the next level until it goes down to 0, until eventually you're all the way up at the top, holding your mouth open, got that thing, making its awful noise, and you're ready for things to begin. Aversive conditioning you've probably heard of most often with addictions, and what we can give you to make you sick if you drink. So you take a sip of alcohol while you're on these substances, you'll vomit extensively, get the dry heaves, the whole kit and caboodle. The problem with aversive conditioning that we find is if we don't have cognitive therapy to go along with it, people will just stop taking the medications so that they can go to Thanksgiving dinner and have a drink with everybody else. And we know that when it comes to alcoholism, one is not an option. So we call the whole thing behavior modification. Several things underneath a behavior modification or changing behavior can be what we call a token economy. And that means just like when you were little and you got a sticker as a reward, you need something like that as an adult as well. What is your reward going to be for behaving a certain way, for doing it the way we want you to instead of not doing it? You have to come up with the behavior, the token that you want, and then you have to follow through on it. It's not like your therapist is going to say, all right, I give you $50 every time you do it, or we'll go out to dinner every time you do it. It's got to be something that you can fulfill, and we can help you find those things and find what levels you're going to have to increase to, and which ones are non-monetary compared to monetary, etc. Now, cognitive therapies are the next one. Cognitive therapies are all about changing your thought or your thinking processes and the way you look at things. So, for example, I have there, you lost your job, so you internalize it. I'm worthless, I'm hopeless. That leads to depression. Now, we teach you, you lost your job, but it's all about your boss. Now, here's the thing. With people that suffer from depression who internalize, they cannot just go to the opposite and say everybody else is a jerk and become very narcissistic about it. So we have to actually teach them the extreme to get them somewhere improved on the depression level of internalization. So we're going to teach you how to start to believe that it's the boss, that you deserve something better, so that we can get away from that depressive thought process. Now, we have all sorts of ones for anxiety. Every area of disorder we can work with cognitive therapy. It's very different to change those thought processes, very difficult to change those thought processes. So we tend to link two of them together, and we call it cognitive behavioral therapy. When we link cognitive therapy and behavioral therapy together, boy, do we really get some significant changes for those individuals. Now, there's mainly three areas of cognitive therapy. We have Ellis's rational emotive therapy. That's to rationalize irrational beliefs. We have Beck's cognitive therapy. He's mainly about depression and about those distorted thought processes we tend to have about ourselves. And then we have Mitchenbaum's stress inoculation training, which means that we slowly start to frustrate you and then teach you how to deal with that frustration so that you can deal with it in the real world. Like I said, the best one that we have right now that's out there is cognitive behavioral therapy, doing both of them together. So you'll see that a lot of times when you look for a therapist, it'll say CBT trained. That's cognitive behavioral therapy trained in the combination of those. Otherwise, we'd like to use what's called an eclectic approach, where we bring in a little bit of everything, and pretty much everyone does that anyway, but we'll bring in a little bit of everything to see what works for you. There's also family therapy, group therapy, and of course self-help groups. Family therapy and group therapy are still led by people that are trained in therapy. Now, self-help groups are not. They are people that have gone through that situation, and because they've gone through it, they now can support those that are just going through it. Self-help groups work just as well, do a very good job of it. So don't have disdain for them just because they haven't necessarily been trained. They've been trained through life. Now, when we compare modern therapies, we have to look at, there's three different slides that go with this. We have the presumed problem. Notice how each one of them have a different problem that they work with. Then we're going to go through a different aim. So when people, again, tell me that, they tried a therapist, they were nice, but that means you need a different type of therapist because they have a different aim. Each one of us are trained. There's a type of training that we go through. We gloss over all of them, but we go more specific into one area. At least the older individuals that are therapists were really trained in one area. And then they get additional trainings later on. But what's their fallback? What's the one that we rely on the most? It's what you've been trained in first. So you're going to find that you may need to change a therapist so that you get a different aim of that therapy. You get a different goal of that therapy. You get different outcomes of that therapy. So look for all of those things when you're trying to find a therapist. And then we go into the technique that's used, which is mainly the way they're trained in. And then know that when it comes to therapy, therapy works. Therapy works 80% of the time. When we look at, and that's any therapy, by the way, but 80% of the time it will work. When we look at any medications, it only works 65% of the time at its max. So therapy works better. But the problem is insurance doesn't tend to cover therapy, where it'll cover medications. And then we also find that medications can cause a bounce back that is very more significant than what you had before. So you stop your medication and then all of a sudden you're worse than what you were in the first place. We don't have that issue with therapy. We can actually train you to not have the issue again in the future, but it takes longer to get there rather than that 24-hour to 7-day turnaround on a pill. Now, here's an example of who you're going to look for depending on what your issue is. For depression, it's cognitive and psychodynamic. Anxiety, you can add in exposure. Phobias, only exposure and behavior. And then children with bedwetting issues is just behavioral. So it depends on what you need to correct as to where you're going to go. A new one that is really up and coming, research is really finding some positives on it, is called the EMDR, Eye Movement Desensitization and Reprocessing. Now, if you've ever seen the old movie or old television show Knight Rider, where it had that kit car, and on the front of the kit car had this, I think it was red, dots that went all the way across, and then it flowed all the way back, and then, one would light up, and then the other one would light up, and the first one would unlight. And so it looked like it was just flowing back and forth. That's really the way eye movement desensitization and reprocessing works. So you can get a little thing that will actually have lights shine or light up all the way across and back. We have the person look at those lights, follow the lights with their eyes, not their head, and then it will keep the area of the brain busy that doesn't want to discuss about that certain topic. So it can be something that's a traumatic event, whether it's vets and a trauma that's happened in that situation, whether it's rape. Some people just can't deal with it to the extent that they push it so far into their unconscious they can't bring it forward. So we will use this to try and bring that out. Now, I know of many people that are using their finger to do it, but it has to be aligned exactly, and it has to go at the exact same pace back and forth. So I know I can't do that. Maybe others can, but I can't. Again, selecting a psychotherapist. You don't marry the first person you kissed in kindergarten and preschool, typically, so you don't always stay with the same therapist that you first went to. Try again. Now, biomedical therapies. So biomedical therapies are all about medications or other type of medical techniques to try and correct those problems. Know that a lot of our medications came from things that were being used all over the place. So there was lithium water that had lithium in it for bipolar disorder, and 7-Up had it, and it gave you, at their campaigns, they said that it took the ouch out of grouch for the lithium soda. 7-Up made your mood up. So that's the whole point to the lithium. You can't just get lithium water. You can't get lithium without a prescription now. But it used to be just something that everybody could have all the time. Here's some of the medications. We're only going to go over 5 of them. Antipsychotics are the worst of the worst that we have out there. They're mainly for schizophrenia or anybody who's having hallucinations and delusions. They block dopamine receptors, that D4 receptor site that's just oozing out dopamine. They block them. Now, the problem with it is it causes massive obesity. Average weight gain is between 50 to 150 pounds. Causes diabetes even if they don't have the weight gain. And the movement problems are called tardive dyskinesia, and it's Parkinson's problems. And Parkinson's medication doesn't work to correct them. Once they occur, they're a done deal and non-correctable. Dry mouth is another one. Dry to the point that it'll actually crack your lips, your tongue, your gums. And you can bleed from them. There's a lot of side effects, and that's why a lot of people would do anything except having to take these things. Anti-anxiety medications, of course, reduce your agitation, your worry, and anxiety. Many people believe that when they're sleeping from them, or if it caused them sleep, then that's what it's supposed to do. Well, it does at the beginning sometimes because you got to get used to it. But what it should do is, what's the 4 hours like afterwards, or the 8 hours after you've gotten up? Are you calmer? Are you less agitated then? We have a real problem with people becoming addicted to these because they take them because they think they should be sleeping, or they should be, almost almost to the point of sleep that they're so calm. It is a slower process and it's a lower process. So we do have addiction issues with anti-anxieties. Antidepressants are, of course, to bring that mood up to reduce some anxious thoughts as well. We use mainly serotonin and norepinephrine. They do have side effects, and our newest group of them, the SSRIs, have the least amount of side effects compared to our tricyclics before that, and even the ones prior to our tricyclics. So they all have side effects. The biggest one that we hear about has to do with the want for sex. When you're depressed, you don't want sex, and sometimes when you're on antidepressants, you don't want sex. So it can be a double-edged sword in some situations. Now, here's our SSRIs. They work more with the way your system works. We discussed this right at the very beginning in the biological stuff. And SSRI stops that reuptake of your serotonin so that you have it sitting out there so it can get to where it needs to go longer. Next one we have our mood stabilizers, and then I have the stimulants for ADHD, not the other ones, just the stimulants. So mood stabilizers, mainly we're talking about lithium here, and you'll notice it says under investigation. If you look up lithium, it'll say, we believe this is why, we think this is why, but they don't have research that has been tested, tried and tried again, that proves it. So do we actually know why lithium works? No. But it does bring down the highs of mania, brings up the lows of depression, and starts to even them out. But they need constant blood monitoring just to make sure that everything's going well, because of course they have lots of symptoms and side effects as well. Now our stimulants for ADHD, why do we give somebody who's stimulated a stimulant? Because it's just like, studying and overstudying, you become more exhausted. It stimulates that area to the brain that it actually calms it. It's the strangest thing. So when it does that, then you can focus more. Now we have some problems with it because it does decrease appetites. We have people that use it off-label, and even those that do use it for ADHD, it decreases appetite to the point that some of our younger children actually can have stunted growth because they're not eating and not getting in the things that they need to grow. Okay. Electroconvulsive therapy is another medical procedure that we have. We tend to only use it for depression, and we only will use electroconvulsive therapy if you've had psychotherapy for a minimum of 2 years and you've been on an antidepressant for a minimum of 2 years. And both of those have to be concurrent. So it's not like you can go on medications for 2 years and then have this done. It's got to be medication and therapy used together for a minimum of 2 years before we'll get to this. Now, why is that? And the main reason is that it does cause memory loss. So it's done on an outpatient basis. Every hospital does it. They give you a little zap, and it's like restarting your car battery. Yours isn't working, bam, we give you a little zap, and it restarts that thing. Now, some people have to go back every 3 or 4 months for this to happen and keep it going. Other people I know of have had it happen once or twice and then never needed it again. We typically tell people you'll have to come back every 3 to 4 months so that they know and their mind is set that this is going to have to happen. Now, when it comes to that memory loss, you're going to not remember that day, but you could not remember days, months, years of your life. It depends, and we can't tell you for each person. Typically, the people that go for ECT have had depression for so significantly for so long, and nothing seems to be working for them, that we have to do this, and they are willing to do this because the way they're living right now isn't living, and so this is the only out for them. Now, there are places other than the United States that are using other versions. Instead of electrical impulses, they're using magnetic impulses. And they find that they do have memory loss, but not as significant as the electrical impulses. They are trying to get them to the United States so that we can use them as well. And for trials, they are using them, but nothing as popular as ECT as of this moment. And the last thing that we have under the medical stuff is psychosurgery, and psychosurgeries can take place. Now, lobotomies were the old ones. We don't like to take big chunks of the brain. It's not good for you. It's not good for survival. It's not good for understanding and cognition. Not good. But you'll find that if you do have a microsurgery, which is typically done by robots, that when the paperwork comes through, it'll still say lobotomy. I don't know why. It still says that. I wish they'd change the name. But microsurgery is getting into an exact neurotransmitter, getting into an exact ion or dendrite and dealing with that. And so that's why it's a microsurgery. And so they have to stop it. Now, I have on there obsessive compulsive disorder. If you remember the slide that we went through that had that yellow and red that became so large, that area was run by one little dendrite. So when you clip that little dendrite off, then we can stop the obsessive compulsive disorder. So there's things that can be done, but those typically are last resorts because we're still digging through the brain to get to where we need to go. And then remember that no matter what type of therapy you're going for, those people are human. So because they're human, it's all the knowledge that they've learned plus everything that they've learned through life as well.